Okay, it's 12 o'clock. Let's get started. Hello, my name is Vecihi Batuman. I'm the interim chair for the Deming Department of Medicine at Tulane. Thank you all for joining today. We are continuing our medical grand round series on COVID-19 related topics. And today I have the pleasure of introducing to you Dr. Eric Simon, my colleague and my friend. Dr. Simon is a professor of medicine at Tulane School of Medicine. He is also the chief of the Division of Nephrology and Hypertension, as well as the program director of nephrology and hypertension. His topic today is kidney and hypertension issues with COVID-19. Thank you, Dr. Simon.
Hey, thanks, Dr. Bodeman. So we're going to talk about several issues relating to the kidney, kidney injury, and hypertension, which I think will be of interest to many people. Here are my disclosures. I'm medical director at DCI and also at the Acute room at Tulane, which is actually run by Fresenius. So what we'd like to talk about today is care of the patients in the ESRD setting, in the chronic setting, then talk about the hospitalized patient and the role of the renin-angiotensin system. So it turns out there's multiple issues that are of interest in the outpatient dialysis unit, of interest in because they're sort of unique. When a patient comes to the dialysis unit, and if they have symptoms, and even if they have symptoms consistent with COVID, the question is what to do about that. We don't have the luxury of simply sending the patient home, telling to quarantine for 2 weeks. We have to find a solution. And in essence, we need to, find a way to dialyze them. And I think the solutions that, that we might have would depend on our knowledge of the spread. And so, during all this, I've actually had to learn a little bit about aerosolization, which now, like, I think most people are hearing. But early on, I was caught into this study of aerosolization versus droplets and surfaces, excuse me, because this will go into how you are going to treat these patients. Here's from the CDC, and this was actually out in March, and here's their guidance for suspected or confirmed, and suspected, of course, what we call PUIs, persons under investigation for COVID in the outpatient dialysis facility. And it's not a long document, but it's a couple pages long. But I want to point out this statement. So a patient comes in, and what are you going to do with them? So they say if a separate room is not available, the mass patient should be treated in a corner or end row station away from the main flow of traffic available, if available. The patient should be separated by at least 6 feet from the nearest patient in all directions. So in essence, they're asking us to, isolate the patient and then dialyze them, which is, would be perfectly reasonable. But again, it gets into this question of, well, how infectious are they? How important are aerosols? How important, are you going to stop all infections with droplet precautions? So these are issues that, that we have to face in the dialysis unit. So, so what we've done then is we've, in essence, followed the guidelines of the CDC. And one of the other statements in the guidelines is, if you have a suspected or confirmed COVID-19, you should consider then cohorting those patients. So we saw what you do when they first come in, you put them at the end of a station, et cetera. But what about later? Well, maybe you should put them all together. But this does present a problem of cohorting the COVID positives with the PUIs. So, early on, it seemed like that was a reasonable thing to do. But later, when we realized that a lot of the PUIs were actually negative, maybe that's not such a good thing to do. Or maybe it really doesn't make any difference if they're not all that infectious anyways and they're all wearing masks. So, we don't have any, great answers, but we, have to deal with the knowledge we have and provide dialysis. One of the things that's really hampered our ability, or at least in the past, to make reasonable assessments was a lack of rapid testing. Now, in the last week, Dave Mushat and Dr. Gary have now allowed us, or at least given us the ability to do some one-day testing. So by the next dialysis, we know if a patient who comes in with symptoms is truly positive. And so that would be of great help. So this is from the Northwest Kidney Centers. It was published in the ASN journal, clinical journal. And in essence, it tells us exactly what we've been doing. Patient comes in with a cough, fever, and if they're screening negative, you just dialyze them. If it's positive, you place a mask. If there's a private room available, no, we don't have any private rooms. We have one isolation room, and that can't be used because it's already taken up by a hepatitis B patient. So they're placed at the end of the road, dialysis, etc. Now, one thing that they had early on, so this is from early in March, and what they had was actually fairly rapid testing already. They would send their samples out to University of Washington affiliate, and they would get them back in a day. So again, they had the ability to make a decision whether they were positive or negative. So other issues in the dialysis unit gets into PPE. Fortunately, so far at DCI, we've had enough PPE. We've also been fortunate that we have only had 1 or 2 nurses that were positive, and most of the patient care technicians, the PCTs, have been okay. There's transportation issues in these patients. So, if they're positive and now they're coming back to the dialysis unit, how do you get them transported? And I think those are issues that are, beyond our discussion today, but it's other things that we have to think about. And then there's the issue of, well, now they're on this COVID positive shift, but most of them are several weeks out. How do we get them back to their usual shift? At this point, there's some variation between dialysis providers. DCI in the last couple of days has decided that we need to get 2 negatives. DaVita is going by the CDC guidelines for someone who basically was not tested. So even if they're been tested COVID positive, they're 2 weeks out, no symptoms, no fever for 3 days, they would be considered basically non-infectious, and they could go back to their usual shift. So let's now turn to the hospitalized patients. And there's several issues that I'd like to discuss. The first is the baseline kidney function is a predictor of mortality. What's the incidence of acute kidney injury in patients that are COVID positive? Does acute kidney injury then predict mortality? And then issues relating to dialysis of these patients in the acute setting. So I know you can't read this, and I have a summary slide in a second. I'm showing it because this was one of the first articles. It was from China, and they had a number of patients, and they have all their characteristics. Now, one of the things that was a little different from them than us is they had very little kidney failure. So if there are 1,000 patients, only 12 of them had a baseline creatinine over 1.5. Now, in those that had severe disease, the incidence was higher than if you had non-severe disease. In other words, they had 4.3% of the patients with a creatinine over 1.5 going on to having severe disease versus only 1% if you didn't have a creatinine over 1.5. We'll see that these creatinines would not be what we see in the United States. Acute kidney injury, they say, was overall 0.5%, and those with severe disease, 2.9%, 5 patients. CRT, 9. So you can already see, though, and I looked to see if there was a typo. You know, these are very rapidly published papers, even in the New England Journal, but that makes no sense, right? That they had 5 AKIs, but 9 CRRTs, meaning that they really have 4 ESRDs. No, if you look through the data, no. So there's just something wrong with the figures. But I can tell you, going through all the Chinese articles, they in general have a much lower incidence of chronic kidney disease than we have in the United States. So here was from Washington State, from Evergreen Hospital. This was exactly the same place as where that I showed you, the Northwest Kidney Center dialysis unit. It's the same region, same place, and they have a higher incidence, and I've blown up table 1 so you can see it, of chronic kidney disease. They had 10 patients of the 21, or 47%, had chronic kidney disease, and 2 of the patients had end-stage kidney disease. So I think this would be a little bit closer to what we would see here in our population in New Orleans. So what is the risk of AKI? So that was the baseline characteristics of chronic kidney disease. What about developing AKI? So there's a number of studies that have been published, some of them in preprint form. A lot of these tables I'm going to show you are actually, and I'll give you the reference at the end of the talk, but it's from this NEPH-JC, or Neph Journal Club, which has summarized a lot of the evidence in COVID and put tables together, et cetera, and discussions. So you may find that useful. But at any rate, they put together this table, most of them for China. But here's the ones outside China. Here's the one I just showed you, Evergreen Hospital. In that place, 19% developed AKI, and they didn't report how many they actually dialyzed. Then there was a report from England, again, that showed about a 19% incidence. And this is in 1,000 patients of AKI, with 19% getting CRRT. So again, not completely clear how those data come together, because AKI does not necessarily say that you have kidney disease so severe you need to be dialyzed. But overall, we'd say that, you know, of those with really severe disease, you know, probably in the range of 20% are going to have severe AKI. What about mortality? So we don't have much data on mortality. Here's a study from, and I have this one starred here because it might be the most relevant, from China. So this is that study. Now, in this study, they had a little higher incidence of elevated serum creatinine and elevated BUN. And let me just show you some of this data. So the title of the paper is Kidney Disease Associated with In-Hospital Death, okay? And what they show is that here's their baseline serum creatinine. And if there was normal, here's the cumulative incidence of acute kidney injury. If they had elevated serum creatinine at baseline, they had a higher incidence of going on to have acute kidney injury, okay? So no controversy there. But what they also showed then was the correlates of these findings with in-hospital death. So as you'd expect, if the baseline serum creatinine was elevated, you did have a higher incidence of death than if it were not elevated. Interestingly, an elevated BUN was actually more predictive of death than the creatinine. If you had acute kidney injury, then yes, the incidence of the cumulative incidence of in-hospital death was pretty high. Here, 75%. And one of the reasons I want to show this was to show you that proteinuria and hematuria were also associated with in-hospital death. So if here's 2+ to 3+ proteinuria, and you had a higher incidence of death. So it was graded, but you know, if you start to have a lot of proteinuria, higher incidence of death. Same with hematuria, more death. So, so one thing that the authors suggest is, you know, pay attention not just to the creatinine, but also look at their urinalysis. If they have a lot of proteinuria or hematuria, this may be warning you that these people are at high risk. So if you then develop acute kidney injury, is it graded? Yes. So this is by the KDIGO acute kidney injury score, which goes from stage 1, 2, 3. We don't need to go into the score. Stage 3, the most severe, does not necessarily mean you've gone all the way to dialysis, but it is fairly advanced acute kidney injury, including dialysis. If you made it to stage 3, acute kidney injury, your risk of death was 5 times higher. So odds ratio of 4.72. So severe AKI was a very bad prognosis. Now, I want to talk a little bit about the potential pathogenesis of the acute kidney injury, which may be a little bit more complicated than we usually see, you know, with infection, where it's usually just garden variety ATN. So here's the analysis of 26 autopsies. And what they show is red cell aggregates, acute kidney injury, ATN, okay, but also they see virus particles in the tubules and also in the podocytes. They can also show that the nuclear protein of the COVID-19 is found in the kidney. So, so their conclusion is you can have direct parenchymal infection of the tubular cells, which may lead to some acute kidney injury. And then this study looked at 6 autopsies and has a couple interesting findings. So again, they see in all these 6 patients an interstitial infiltrate. Here on the left hand of each of these is the lower power view, and the box shows their higher power view. And in all these cases, you see an interstitial infiltrate of lymphocytes, which would not necessarily be what you see in garden variety ATN. What they show is, they also showed antigen, COVID antigen in the kidney, but also CD68 is a macrophage marker. So now you've got macrophages infiltrating the kidney. And interesting, this is, I think, really interesting. In B, they're showing C5b9. So that's the membrane attack complex for the alternate pathway, which is staining in the kidney. Now, this summarizes their results. Again, they show the virus antigen in the kidney. They show the membrane attack complex on all the cells. They show macrophage infiltration. And, you know, when you see this membrane attack complex in the kidney, and you know that some of these patients have low platelets, they seem to be hypercoagulable. I just thought, well, yeah, maybe you should think of this as at least some of these patients as some variant of hemolytic uremic syndrome. And so I looked to see, well, maybe we should try eculizumab. And sure enough, Solaris, which is the company that makes eculizumab, already has a trial in place to look at eculizumab in these patients. Now, how did they jump on this so fast? Well, it's because, and this was from 2018, so this is pre-COVID-19, this is actually from SARS and actually other virus infections where complement activation contributes to severe acute respiratory distress. So this company was already thinking of eculizumab before the COVID-19 broke. Now, we said that the previous study had shown that, that you could see COVID-19 in the podocytes. And this study is from Dr. Sharshir and Dr. Saka from our division. And this just is coming out, collapsing glomerulopathy, which is focal and segmental glomerular sclerosis in at least a form of FSGS in a patient with coronavirus. They were fortunate in that they were able to do the biopsy before the outbreak really broke. She turned out in retrospect to have COVID-19, but they were able to do the biopsy because now you can't do any biopsies because it's not considered an essential procedure. But at any rate, they were able to show FSGS and also Arcana, I'm sorry, this seems to have a mind of its own. Arcana Labs, which does our histology now, is able to do the ApoL1 testing on the samples. They do it in situ. Now, it's a little beyond the scope of this talk to talk about ApoL1, but just to say that ApoL1 has some genes that are variants that are called risk factor variants. They're found in African Americans, and it is probably the reason why African Americans are so prone to kidney disease, especially FSGS. So this patient actually had an ApoL1 risk variant. With ApoL1, it usually takes more than the variant. You have to have a second hit like hypertension, or it could be HIV. So collapsing glomerulonephritis is what you see with HIV, and it was seen here. So this really suggests that COVID-19 may be causing, maybe the cause of the problem in the face of the ApoL1 variant. So as far as the potential etiologies for acute kidney injury, then certainly we can have garden variety acute tubular necrosis, which you can see with any infection. There is some evidence for rhabdomyolysis, and I think we've seen that clinically. It may not be severe, but many viral infections will cause rhabdomyolysis, sometimes very severe, maybe contributing to the acute kidney injury. There's always the issue of medications, but maybe unique for COVID-19 is the direct invasion of the kidneys. And this directive invasion, which we'll come back to, maybe because the kidneys also express the ACE2 enzyme. And so with the invasion of the COVID-19 in the kidney, you could have a direct cytopathic effect. We saw recruitment of macrophages to the interstitium, assembling of the membrane attack complex on the brush border, and also, as we just said, there could be podocyte injury, which may be a cause of FSGS. So, having established acute kidney injury, some of these patients are going to go on to dialysis, or we may have patients with end-stage kidney disease that need dialysis. So there are challenges in providing dialysis in the ICU with COVID-19. One of the challenges is that you put the dialysis machine there, and do you have to open and close the doors? on a patient who's on a ventilator. There's an issue of nursing availability. There's an issue of machine availability, dialysis supplies, clotting of lines, and what to do with the effluent of the dialysis machine, depending on what kind of dialysis you're doing. So, so given some of these challenges, one of the things that you can do then to treat kidney failure and maybe not have to exhaust all your dialysis is to limit fluid intake, generous use of diuretics, and also maybe not start dialysis, very early. And one of the things that we found over the years, and this is from 2018, this is not COVID, this is sepsis, that perhaps that you don't need to start renal replacement therapy, extremely early. That maybe you can wait a bit. So this trial was stopped early for futility after the second planned interim analysis, and they concluded among patients with septic shock who had severe acute kidney injury, there was no significant difference in overall mortality at 90 days between the patients who were assigned to an early strategy for the initiation of replacement therapy and those who were assigned to a delayed strategy. So, so this is one, and this is only one paper. There's another important paper that showed basically the same thing. So there's not a lot of good evidence that you need to start really early. Certainly when you need to start, but not to necessarily start prophylactically. So the indications to start RRT, and this is from WashU. There was an ASN seminar on COVID issues that I've taken some of this material from. So their opinion about the indications to start RRT, certainly if you have volume overload or respiratory failure, to remove volume. Hyperkalemia, severe metabolic acidosis if they're uremic, or severe oligonuria. Now, they again are emphasizing be wary of aggressive fluid resuscitation. Although since this webinar, there's also been some the meeting of the ICU physicians in Great Britain, and they had a sort of a task force, a seminar. And what they noted was that perhaps we were a little bit too aggressive with the fluid restriction, the furosemide, in that they thought there were a lot of patients that were actually becoming very pre-renal to the point where they did need RRT. So they were actually becoming too dry. So I think that we have to be a little bit careful. We don't want to do aggressive fluid resuscitation, but we don't want them to be overly dry. And the fluid resuscitation maybe use balanced crystalloids so we can avoid some of the metabolic acidosis. A trial of high-dose diuretics, loop diuretics, especially if they look like they have intrinsic kidney failure and they're going to perhaps wind up on dialysis. You just don't know yet. And again, there's no data to support early initiation of RRT. So if we decide then we're going to do RRT, we have several choices. And I just wanted to remind everybody what these choices are. And there's a lot of jargon here. So one of the forms of treatment that you can use is CVVH or CVVHD, continuous veno-venous hemodialysis. And what that's come to mean, even though it's similar to others, is that you're doing a low efficiency dialysis, usually for 24 hours, using usually the next stage machine, which I'll show you a picture of, or the Prisma machine. And these have bags that you hang. Now, PERT is basically CVVH using the same machines, but it's more intensive dialysis, so you're increasing the flow rates of the dialysate. So you can now do it maybe in 8 hours, what you would normally do in 24 hours. SLED, you're using a conventional dialysis machine, but you're doing it at a slower dialysate rate, so it's less efficient, so you don't have as much disequilibrium, and you have the chance to pull fluid over long periods of time. But it is much more efficient SLED than CVVH. You can do intermittent hemodialysis, but it has its limitations because if you have somebody who's sick and on pressors, you may be able to get by with intermittent hemodialysis, but you do have a problem of actually pulling enough fluid in the limited time you have to do intermittent dialysis, which is usually just a couple of hours, up to 4 hours, but usually 2 or 3 hours. And then using peritoneal dialysis acutely. So this is from, again, the ASN webinar, and I've adapted, I didn't show you all their adaptations, but these are some of the adaptations they did at Montefiore in the Bronx, and they were hit very hard with this problem. So, so as we mentioned, you may increase the threshold for renal replacement initiation. You can use potassium binders, sodium bicarb, and diuretics. May have to decrease the dialysis frequency, shorten treatment times, at least when clinically you're able to do that. You could increase patient, you could put patients into cohort, COVID cohorted rooms, and you may have to increase the number of dialysis machines that you have available. They were initiating some patients with peritoneal dialysis. They would implant tank-off catheters at the bedside by transplant surgery, or if they were able to go to the IR suite, do it by IR. We actually did a couple of cases, or actually LSU did a couple of cases at UMC. Only one of them really worked. But I can tell you that peritoneal dialysis is a good modality. When I was a house officer, we really did peritoneal dialysis for all acutes. We didn't really do hemodialysis. It was a different world and different setups. We actually placed the catheters as house officers. When I was an intern, we put in the PD catheters, and it worked very well. Peritoneal dialysis does have a problem, though, in these COVID patients, because you could only do it if they're not going to be prone for a long period of time. People are saying, well, if you did 12 hours on, 12 hours off, you could do peritoneal dialysis. But if you were 16 on and 8 off, you just couldn't do PD. So you have limitations on PD, but people are doing PD just to try to ease the burden of on the dialysis nurses and ICU nurses for hemodialysis. So they were purchasing more cyclers, PD cyclers. They were, which also would help conserve nursing time. And they were trying to conserve use of their PPE and palliative care consultation where appropriate, and that is happening at UMC. So what about protection of the healthcare providers? So the patients are masked during the procedure. They use all droplet precautions. The dialysis nurses are using full PPE. They want the dialysis staff to have limited direct exposures to the patient. So this is a problem. We originally thought, well, you know, we didn't want to close the doors all the time. But on the other hand, to not open and close the doors, if you have the dialysis machine in the room, the nurse, it's hard for the nurse to monitor. So what are you going to do? One would be to place the nurse in the dialysis, into the patient's room for the time of the intermittent hemodialysis, like 3 hours. But I think we've come to think that that's probably not a good idea. what they also did was then to use extra long tubing to distance the staph. And here's a picture of that. You've got the Fresenius machine here and the next stage machine here. What's the difference? So the Fresenius machine is what you use for intermittent dialysis and also for SLED. And it mixes the a dialysate concentrate with reverse osmosis water at the machine. One problem in trying to move the machine outside the room is it's got these long water lines that are pretty thick. Now the next stage machine, like I said, has self-contained bags that you hang, and the effluent comes down here into another bag, but there's no plumbing involved. So if you have that particular setup, and you can tell this is a next stage machine because it's got the bags down here, it may be a Prisma, they're the same principle. But what they've done is they have these lines then, these are long blood lines that they've hooked the patient up to, so the blood line goes all the way out through the door to the machine. And what they tried to do initially is put it under the door, but people were stepping on it, so they put it between the doors. Not ideal because the door is slightly cracked, but you know that may be the best solution that you have for this. So the other thing that they're doing, if you're going to put the machine outside the room, is to use baby monitors. So you can use baby monitors both to look at the patient, but also the baby monitors usually would have an enuresis monitor to see if there's any blood leaks. And then as far as the staff, you want to limit the number of staff entering the patient room for the physical. So the nephrology team does not really go into the room every day for the physical exam. It's not ideal, but we're going to rely on others to have done the physical. Therefore, we have to communicate with the primary team about any complaints, their exam, treatment plan. And then if you do go into the room, of course, you use full PPE. And in New York, everybody was now wearing masks. So this was early on, they were wearing masks. Other problems with the dialysis, and we've seen this here, and that is that the lines are tending to clot. These patients that wind up with severe COVID-19 are hypercoagulable. And so there's a lot of clotting, and what's recommended then, and this is from WashU, is to fully anticoagulate anybody, certainly, who's going to be on CRRT. I know that we're doing some anticoagulation, maybe not full anticoagulation of people that are not on CRRT, but if they're going to be on CRRT, full anticoagulation. We don't have citrate here. We actually were trying to get that going again in January, but we haven't really started again. And the recommendation is if you're not using citrate, don't start using it now. The advantage of citrate, it probably is a little bit better anticoagulant than heparin. And if you're going to use heparin, there is a protocol that WashU provided. So another aspect of chronic dialysis, or I'm sorry, acute dialysis, well, acute and chronic actually, is dialysis access. So early on, we were told that we could not do any procedures for dialysis, that these were not emergent procedures, and we needed to protect our PPE. The American Society of Nephrology went to bat, went to CMS, and there was a statement from CMS then that said that, no, you need to do certain procedures. So there is now agreement that if a fistula is clotted, it should be declotted, that perm casts will be placed, that if you're going to do acute start PD, the PD catheter should be placed. But at this point, we're not going to place any new fistulas. Now, the issue of transplant, I think, is a little bit, again, beyond the scope of this talk. And there are resources to look at if you have a patient who needs some decisions about immunosuppression. But basically, the transplant team will help you. And the recommendation is just the blanket, which is, maybe not true completely, but in general, hold all immunosuppression except for steroids. So that brings us to this issue of hypertension, the ACE2 receptor, which I mentioned briefly, and the role of the renin-angiotensin system. So first, hypertension, is it a risk factor? So, so most of the studies that you'll see say that they'll list the risk factors, and they'll tell you, of course, diabetes, and then they'll say hypertension. But the problem is at this point that there's not been a lot of stratification of hypertension by age. And we know that the incidence of hypertension goes up in the general population with age. And in fact, the incidence is not very much different from the incidence of severe COVID with age. So it's not completely clear that hypertension really is an independent risk factor for severe COVID, because there's been no controlling for other variables. Then people said, well, it must be because of this ACE problem, and then the renin-angiotensin system is involved, and maybe ACE inhibitors. So what do we know? So we know that ACE2 is the receptor for COVID-19, which brings up hypothesis one. So this is from the New England Journal, I guess last week, that the inhibition of the renin-angiotensin system is harmful. Why is it harmful? Because this ACE2, angiotensin converting enzyme 2, is the receptor for the COVID-19 spike protein. So it binds to ACE2 and then is internalized and infects the cells. So, so what might be the problem with the angiotensin converting enzyme inhibitors or the ARBs? So first of all, just to say, ACE2 is not inhibited by your ACE inhibitors or ARBs. It's a different enzyme. It is not inhibited, but it is part of the whole system. And it may be increased by ACE inhibitors or Arbs. And do we have data for this? Well, there's some animal data, and it's from the heart and the kidney. The lung has not been examined, that says that ACE and Arbs could increase it. But the evidence actually is contradictory in these animal studies. The human studies, and there's no good evidence from the human studies either, but even if you have evidence, they're going to be looking at soluble ACE and not membrane-bound ACE, and we'll come back to this soluble versus membrane in a second. So far there's no evidence from animal studies that upregulation of ACE2 is involved in increased infectivity. This paper, which I'll come back to in a second, showed the following. So here we finally have some look at the incidence of ACEs and Arbs in the hypertensive patients. And what it shows is that before infection, or just the general population, you have 1,900 patients, 35% of them are on ACEs or Arbs. And of those that were infected with COVID-19, 34% were on ACEs or Arbs. So it didn't look like there was any evidence that, that ACE and Arbs made you more susceptible to having COVID-19. So this brings us, though, to the second hypothesis, and that is RAS inhibition is actually protective of COVID-19, decreasing lung injury. So how could that happen? So the effects of the ACE and Arbs, we said, may be to increase ACE2. And if that happens, it may actually increase angiotensin II degradation, which I'll show you in this figure here, which maybe is a little more helpful than being a journal figure. So here's your regular ACE, and here's ACE2. So angiotensin converting enzyme converts angiotensin 1 to angiotensin 2, which then binds to its receptor. So what does ACE2 do then? Well, ACE2 actually, angiotensin 1 or angiotensin 2 is 8 amino acids, and ACE2 clips off one of them to produce this Ang1 to 7, which is actually a vasodilator. It actually opposes angiotensin 2 effects. ACE2 also converts Ang1 to Ang1 to 9, so inactivating this, so it can't go on to angiotensin 2. So those could be good effects if you're actually antagonizing angiotensin 2. The virus, when it binds to angiotensin 2, is internalized, as we said, but also, so then it decreases the amount of ACE2 on the, at the apical surface, and this could be pneumocytes. So what do we know? Well, RAS inhibition may actually attenuate the injury with, this is SARS, not COVID-19. And in other animal models, RAS inhibition attenuates lung injury. So this is from an article in Nature, which showed that that the SARS spike protein decreases the ACE2, like we said, but RAS blockade actually attenuated lung injury. And this study was the one I showed you the results from the ACE and ARB data. In that study, they compared the ACE and ARB group to other hypertensives. And what they showed was that the patients who were on the ACEs and the ARBs actually had lower concentrations of CRP, lower procalcitonin levels. And these next two did not reach statistical significance, but they had a lower proportion of critical patients and a lower death rate. So ACEs and ARBs did not, if anything, were beneficial. And so, so I searched and found that there are two studies now that are looking at ACEs and ARBs in coronavirus. So this study and this study. So there's going to be two studies looking at the effects of ACEs and ARBs in coronavirus. Another interesting aspect is this. So the ACE is membrane bound. The ACE2 is membrane bound. It's cleaved by this atom 17 and becomes shed. Now, what happens if it's shed? Well, it may bind the coronavirus and therefore not allow it to enter the cell. So this is from Daniel Bataille, who actually is a nephrologist, and I don't know exactly how he got into this thing, but he's part owner of this company that's going to look at this peptide which is basically mimicking the receptor. And if you can flooded with this peptide, that perhaps you could stop entry. So these studies are being done in Germany and in China. Another interesting aspect is this. There's a enzyme on the cell that cleaves this TMPRSS2, cleaves the spike protein, which is called priming. And this is actually necessary for it to become active. And as it turns out, this TMPRSS2 has an inhibitor. And this inhibitor is called camostat mesylate. And there's companies that have been looking at this because it's actually found on in prostate cancer. So there's some talk of doing studies with this inhibitor of this TRMPSS2 that perhaps inhibiting TMPRSS2 would inhibit virus entry and decrease infectivity. So the summary of RAS blockade is that there's no evidence for promoting COVID infection. It may attenuate lung injury with severe COVID, and stopping ACE inhibitors may therefore have deleterious effects, as always, on blood pressure and heart failure. And heart failure is a very prominent aspect of at least some of these patients. And the ACE2 is found in the heart. And so there are multiple professional societies that have suggested that if the patients are not, if they're not on ACE inhibitors, probably not starting them right now, but if they're on them already, do not stop them. And with that, I will end, and I leave this reference, if you want to jot it down, the nephjc.com, which has a lot of information on kidney issues, most of which I've talked about today. So thank you. See, we can't hear you.
Yeah, thank you, Dr. Simon, for this wonderful presentation. We have a few minutes and we will be able to take some questions. What I suggest to the participants is, if you have any questions, quickly type it and I will read it to Dr. Simon. We give a few minutes so far. Okay. There's one questioner is saying, based on the ACE-ARB information, do you still recommend stopping the medication in AKI as we usually do?
No, I don't. I think it depends on the circumstance, but I generally, I don't actually love the idea in general of stopping the ACEs and ARBs and AKI. That, this is sort of off the COVID topic, but in general, it's sort of cosmetic in some ways. You say, well, you stop the ACE and ARBs, maybe the kidney function will be a little better, but there's some evidence that actually continuing the ACEs and the ARBs may be beneficial to the long-term outcome of acute kidney injury. So in general, I don't think so. Now, hyperkalemia is another issue. So I probably would not stop the ACEs and ARBs with AKI. And those patients that have AKI, again, are going to be at risk for severe infection, including, or at least outcomes, including lung, and you may be better off on your ACEs and ARBs.
Okay. Another questioner is asking, could you explain the use of diuretics with acute kidney injury?
Well, the use of diuretics with AKI, again, this is sort of beyond COVID, but the use of diuretics can be both diagnostic and therapeutic. if somebody actually responds to diuretics, what it means is that they have probably less severe acute kidney injury, because if you have very severe acute kidney injury, they don't respond to diuretics at all, which has brought up this whole thing with the Lasix challenge test, where you give Lasix and find out if they produce urine. If they produce urine, that predicts a better outcome. But you can also use it therapeutically, and in this case, it's being used therapeutically because some people with AKI, and even with structural kidney injury, will respond to diuretics, and that may be helpful. But again, as I said, that we probably shouldn't overdo it. And just to also reiterate, AKI is a broad term, maybe not the greatest term, because AKI encompasses both pre-renal, and it's anything when the creatinine goes up, pre-renal or intrinsic renal failure, like acute tubular necrosis.
Okay. Another question is, any speculation aside from APOL1 variants as to why COVID-19 is so deadly in the African Americans?
No, I think that the APOL1 would only explain perhaps focal and glomerulosclerosis. It doesn't really explain any other AKIs, and certainly, as far as I know, doesn't explain any of their lung problems. I think that problem has more to do with other comorbidities.
Okay. Question from Dr. Keith Ferdinand. Is usual clinical lab estimated GFR adequate to determine CKD, especially in Blacks and large body mass athletes?
Well, probably not. I think that if there's a question, what we've done is actually sent off a cystatin C. The only problem with the cystatin C is it takes a couple days to get back, but you usually get it back in 3-4 days, and that would help you at least going forward, or maybe even in retrospect, decide whether or not their GFR was from influenced by their muscle mass. As you said, African Americans may be increased. Another common problem is when they have low muscle mass and they have normal creatinines, and they may actually have very severe kidney problems if they have very little muscle mass. So we've been using cystatin Cs to help adjudicate that.
Okay. Another participant is asking, was there any evidence of thrombotic microangiopathy in the patients who developed AKI with COVID-19?
I showed you they had some red cell aggregates there, but I don't think that they specifically showed thrombotic microangiopathy. But I would say that the evidence is pretty limited right now, because we just have those few autopsies at present that were reported. So I don't know, and if thrombotic microangiopathy is playing a role, I don't know if it's playing a role in every patient anyways, maybe just a subset of patients.
Okay. Another question is, we're coming to the end of our time, and I'll take this one too. DPP4 was identified as a functional receptor for the spike protein of MERS coronavirus. Is there any evidence of antibodies directed against DPP4 in COVID treatment?
I have no idea.
Okay.
I don't have any information on that.
Okay, thank you. The last question, I'm sorry we will not be able to take any more. The last one is, since ACE2 is the receptor for COVID-19 virus to enter human cells, do you know anyone or pharmaceutical companies are trying to inhibit ACE2 or block ACE2 to prevent and treat COVID-19 infection and complications?
None other than what I already mentioned, that is trying to flood with soluble receptor peptides that mimic the receptor binding site, and perhaps the other agent, the chemotherapy agent. It's not really a chemotherapy agent, but the one that's used in prostate cancer. I don't know of any others that are looking at blocking the receptor, but certainly I'm sure people are looking.
Thank you very much. I want to thank Dr. Simon for this excellent presentation and for the audience for the provocative and intriguing questions. And this brings us to the end of our presentation today. Thank you all.